Hello, everyone. Sorry we're running a minute late. We had a minor technical issue, but thanks for joining us today. This is Shannon Kieran. I am the co-chair of the Genomic Technologies SIG, and we're here today joined by Kimberly Banks and my co-chair, Jillian Sotelo, to present on blood-based assays for the detection of early-stage cancer and recurrence of disease. Just a few housekeeping notes before we get started. This is a webinar that's applied for and accredited for CEUs. So for those of you who are interested in collecting CEUs, there is a quiz and an evaluation at the end of the webinar that will be provided in an email link to you afterwards. Do make sure that you complete that. And we will have several other webinars coming up in the series over the year. We're planning to do one about every 8 weeks now through the month of November. We hope you can join us for many of them. I'd like to introduce our speaker today, Kimberly Banks. Kimberly received her bachelor's in molecular and cellular biology from UC Berkeley in 2002 and her master's in genetic counseling from California State University Northridge in 2004, and went on to get her MBA in 2013 from UC Irvine. She's completed a one-year fellowship in cancer genetics at the City of Hope and then became the first genetic counselor at St. Joseph's Hospital in Orange County, where she worked for 7 years. After completing her MBA, she joined Ambry Genetics as Director of Marketing and transitioned in 2015 to Guardant Health, a circulating tumor DNA genomics lab, where she's currently the Senior Director of Medical Affairs. And with that, I want to turn it over to Kimberly to teach us about blood-based assays for cancer.
Thank you, Shannon, for the introduction, and thank you everyone who has joined today. I'm very excited to speak with you on this topic. And to start off with, as a disclosure, as Shannon just mentioned, I am an employee as well as a shareholder of Guardant Health, a company developing blood-based assays for detection of early cancer and recurrence of disease. Throughout this topic, I have removed all assay trade names to avoid any bias or perceived conflict of interest in giving this educational talk. So with that, the webinar objectives are, and actually let me do a quick check here because I do have dual screen. Shannon, is the visual showing one screen, one slide, or two slides side by side currently?
We just see the one slide. It looks good.
Okay, perfect. Thank you. All right, well, with that, I will continue. So webinar objectives are to review the hypothesis and methods of the ECLIPSE prospective research study for assessing early detection of colon cancer in healthy average risk subjects, to describe how and when to utilize liquid biopsy assays, focusing on detection for early stage cancer in the clinical setting, and evaluate the limitations of blood-based assays for early detection. And so to start out with, when we're talking about blood-based assays, there are multiple tumor-derived elements present in circulation. And tumor proteins in the upper left here are widely used today in the realm of cancer management. So things like CEA, CA125, many of these protein biomarkers are considered the standard of care in monitoring existing cancers and have been explored in ability to detect early stage cancer. And so for the rest of the talk, we're going to focus on the rest of what is present in circulation, which all together are loosely comprised as what we call liquid biopsy. And so this ranges from circulating tumor DNA, circulating tumor cells, circulating tumor RNA, tumor-educated platelets. So lots of additional information from cancer cells that is shed into the bloodstream and thus, in theory, detectable via a blood test. When we come to then the term liquid biopsy, the majority of work to date in terms of both development, academic companies, for-profit companies, et cetera, as well as commercialization of these assays, has primarily focused on cell-free DNA-based approaches and circulating tumor cell approaches. There's a lot going on primarily in academic labs in the other space, but most of what you'll hear about or have potentially run into in clinical settings with oncologists ordering are either cell-free DNA or circulating tumor cell based. And so from those two analytes, there's a range of things that can be assessed. So looking at doing genotyping of the tumor or genomic profiling of the tumor, looking at point mutations, chromosome abnormalities, translocations or fusion events, amplifications, and then primarily through circulating tumor cells, which can contain proteins and RNA as well, looking at expression there. And across all of these different pieces, there's a lot of promise around liquid biopsy, and hopefully it's promise and not hype in terms of the questions that liquid biopsies can potentially address. Everything from, we talked a little bit about being able to provide genomic profiling of the tumor. So what are the genetic changes present in the tumor that would align with targeted therapies that have been approved or in clinical trials? But then also the question around, is treatment working? Has it spread? Is there any cancer left? In kind of the holy grail of, can we get to a blood test that screens for cancer? So across the continuum, liquid biopsy has potential everywhere from screening to diagnosis to therapy selection and monitoring. And given this broad potential use, it shouldn't surprise anyone that this is a very, very crowded space. So there are more than 100 companies developing assays across the potential clinical applications. And I share this so that you're kind of aware of how much is going on here, as well as a little bit around, you'll see around the legend that, again, most of this is focused on cell-free DNA and circulating tumor cells. As a clinician, I think a bit more kind of into the patient journey. So when we think about the oncology continuum of care, laying out, thinking about screening for cancer, hoping to catch it early, treating it early, and for the subset of patients that they have advanced disease, either at diagnosis or progress to advanced stage, what are the ways that circulating tumor DNA or liquid biopsies can assist across the continuum? And so we talked a little bit about that holy grail of, can we get to a blood test for screening? And we'll talk a little bit, we're going to talk more about that in today's lecture. When it comes to early stage cancer, a lot of questions related to, okay, patient has gone through the current standard of care, but are they cured? Did we get all of the disease? Or is there potentially residual disease? And in this instance, we talk about molecular residual disease in the presence of tumor DNA still present in circulation. And so what can we do with that? Can we do the assays work in that way? Are they sensitive enough? And how do we use it? And then beyond that, into the surveillance realm in monitoring these patients, can we get to a blood test that can be used to monitor patients in a very sensitive and specific way? And then in late stage cancers, that is really the realm of where a lot of precision oncology and precision medicine has made strides on the drug side. And so now we have, last time I looked across the NCCN guidelines, there are more than 20 genomic markers relevant across 17 different solid tumor types, where if that genomic marker is present, a targeted therapy is available to patients. And so when it comes to these theoretical use cases, the one that is not theoretical today is the advanced stage cancer patient use. So this, much of what's going on in liquid biopsy over the last 5 to 6 years has focused on late stage cancers, providing a means of non-invasive genomic profiling of the tumor to identify those targeted therapy options. And that is all I'm going to say on that topic today, because it's not the focus. Our focus is, what about early stage and screening? So what I'm going to go through to show you the data and the status of early stage uses. By the end, I believe you will agree with the conclusion that the liquid biopsy assays, their performance in this use case has been documented. And now the question is, just because we can prove that there is molecular residual disease in a patient, does intervening early make a difference? Is there clinical utility to that information and changing care based upon it? And there are a number of trials that have been initiated there, so we'll go through those. And then when it comes to screening, primary screening, we'll go through the approach to the assay development to date, as well as the handful of trials that have been started and the timelines for this becoming clinically relevant. So as we think about this trajectory, obviously we hope to get to a point of having a blood test for screening and we detect cancer early. But akin to drug development, the liquid biopsy space has started in advanced stage disease and is now moving kind of backwards into early stage. And the main reason for that has to do with the levels of circulating tumor DNA and our ability to detect that signal. So this summary here over stage 1 through 4 disease across a number of different tumor types is a summary of multiple different publications, but essentially stage 4 disease, not surprisingly, patients have more lesions, more tumor volume, more aggressive disease. And so the cell turnover and release of DNA into circulation, it's at detectable levels. It's still low levels. It's much lower than what we see in NIPT in terms of the fetal fraction, but it is much higher than in early stage disease. And so the technologies, the introductory technologies for liquid biopsy have been very successful at finding the signal, returning a result in advanced stage cancer. As we talk about moving backwards into earlier stage use cases and then screening, we see that stage 1, stage 2 detection rates are about 50%. And so there are there are enhancements needed in the technology or different approaches to improve sensitivity in early stage disease to have a truly robust option for screening as well as early stage uses. And so there are two main methods that are being applied to improve sensitivity above and beyond the liquid biopsies that are currently available. And as one thing I skipped over, the majority of liquid biopsies that are in clinical use today for that advanced stage use case are focused on, again, the genotyping. So they're looking for presence or absence of gene-based mutations. And so what's going on to improve sensitivity as we move into earlier stage use, what method is applied for improving varies by the use case. So if we think about stage 1 through 3 cancers and liquid biopsy development there, the two main approaches to improving sensitivity are laid out. So the first one is going forward in a tumor-dependent approach. So you're essentially predefining what you're looking for in blood. And most of the development and the assays that are available here take the surgical specimen or the diagnostic biopsy, perform whole exome or whole genome sequencing, identify a panel of clonal mutations that are present in the tumor, and then design a bespoke or personalized PCR-based assay of anywhere from 10 to 20 predefined mutations based upon the tumor sequencing. And then that personalized blood assay is applied at the various time points to look for presence of residual tumor DNA in circulation. And so the strength of this approach is that by predefining what you're looking for in blood, you can sequence deeper and improve the sensitivity without losing specificity. One of the concerns as we sequence deeper into the cell-free space is we start to question, is the returned result tumor-derived? Could it be related to clonal hematopoiesis of indeterminate potential? So it's a somatic alteration, but not tumor-derived. Is it a false signal in the sequencing platform due to the depth of sequencing? And so if you predefine what you're looking for by looking at the tissue first, you have confidence when you see that mutation in the blood results. Now, the limitation of this approach is that it does require sufficient tissue for that whole exome or whole genome sequencing. And there's a logistics component to it in terms of the time for sequential tissue testing and then designing a plasma assay and applying that plasma assay. And so there's a lot of this work is very promising, but as clinical trials are beginning that leverage this type of technology, there are concerns about the time frame and will results be returned quickly enough to put the patient on therapy if needed versus you miss the window, so to speak. So the other approach that is being pursued to improve sensitivity in early stage disease is sticking with a blood-only approach that we see in the liquid biopsies available today for advanced stage cancer use, but it's leveraging additional information present in the cell-free compartment. So not only looking at the genomic or the somatic gene-based calls, but adding in epigenomic signal capture and analysis. And so this can include methylation, looking at the methylation profiles to distinguish tumor from non-tumor DNA, as well as differential nucleosomal positioning in the tumor versus benign tissues that ultimately the cell-free DNA is in short, about 150 base pair fragments, but based upon some of the methylation profiles, other information present in the tumor DNA, not present in the germline cell-free DNA, the actual nucleosome and the number of nucleic acids that are wrapped around it can vary slightly. And so we get this, what we call fragmentomics, where there's actually differing fragment lengths between tumor DNA that is and germline DNA that is in the cell-free space. So very exciting, a lot of research and early data here that I'll show you on this promise of looking at the epigenomic signals as well to enhance the sensitivity. And so that is, again, the strength. By looking at multiple signals, it improves sensitivity. The limitations here are that the epigenetic signals heavily, especially in methylation, vary by the cancer type. And so the development and validation time is longer. It's a bit kind of cancer type by cancer type. And the added benefit of the epigenomic signal varies by cancer type. And so there are some cancers that I refer to as methylation happy, where they have a very distinct methylation profile that is robust and differentiated. Other tumor types do not have such a strong signal on the methylation side, so it'll become more dependent potentially on fragmentomics or other signals. And so this is very promising for the blood-only approach, but the development is a bit more in-depth. And as we now think about, okay, this is for improving sensitivity for these assays to perform in early stage disease, if we think about then primary screening to detect cancer, well, all of the work there is focused on the blood-only approach, because by definition, we do not have tumor in a screening population to predefine what you're looking for in blood. So all of the work that is going on that I'm familiar with and found through an updated literature review for primary screening is focused on these blood-only approaches and leveraging multiple signals in the blood. So with that, let's dive into, now that we've kind of walked through how circulating tumor DNA fits across the continuum of care, either proven or hypothesized, as well as what's going on the technology and the development side. I'm going to walk through what data we have in these two different spaces and how close or far we are from them being clinically available and relevant. So with early stage uses, if we go back to this framework of all these potential questions that liquid biopsy can address, the main focus today of liquid biopsy use in early stage disease is around the questions of, are treatments working, and are there any cancer cells left or cancer DNA left after treatment? And the other note I'll make is that as targeted therapies transition from advanced stage use into earlier stage use, and those pharmaceutical trials are ongoing, in the near future, liquid biopsy for that purpose, for genotyping of the tumor, will likely also become relevant. But for today, we're going to talk mostly about these questions of, is treatment working? Is there cancer left? How does a liquid biopsy assay fit in there and provide information? And the clinical question essentially that we're trying to answer is, has the patient been cured? And or who is going to recur? And so if we kind of, again, for putting my clinician hat back on, I like to put this in the framework of how does this fit into the patient journey? So I think a lot of us in cancer genetics have robust exposure to breast cancer and breast cancer treatment. So I chose that as the example, but this theory applies across. So patient has their diagnostic biopsy. They've been told they have cancer, And the treatment plan is laid out based upon their stage and other pathology-based assessment of the tumor. And so in breast cancer, this patient laid out here is proceeding with neoadjuvant chemotherapy, going on to surgery. And ultimately, the hope here is that this is the goal of curative intent. We removed the tumor that we know about, that we can see on imaging. We are applying systemic therapy so that if there are any rogue cells that have broken off that could lead to a recurrence, either locally or distant recurrence, that the systemic therapy will kill those cells, and thus we've removed all of the tumor and the patient is cured. And this applies, we can flip those around and we can say surgery and then adjuvant therapy, regardless, the goal is cure. But the question is, did it work? And so a lot of data is being developed around about 2 to 4 weeks after completion of the standard of care therapy, in this instance showing it post-surgery, performing a liquid biopsy to look for the absence or presence of tumor DNA in circulation. If there is tumor DNA present, that suggests that there are still cancer cells present, and thus we have not cured the patient. The following question is, then what do you do about it? And I'll show you some trial designs that are ongoing to test that intervening based upon that makes a difference. And then let's say the ctDNA liquid biopsy test comes back saying, nope, no tumor DNA present after surgery, looks like it's all clear. Well, then the question is it clear or is it just below the detection levels? And so there's a lot of debate around also using liquid biopsy in the monitoring approach every 3 months, every 6 months, very much to be determined and vary by cancer type. But again, the same question of if we detect tumor DNA in circulation, that gives us the signal that the tumor is still present or has come back. Often, I don't have the data added in here, but there is a lead time of the tumor DNA reappearing when the cancer cells when it's still microscopic, so not present at imaging, and anywhere from 6 to 9 week or further lead time, multiple month lead time before imaging would show that the cancer has recurred. But again, the question here is, if you intervene, do you still improve outcomes? And so that is the focus of the trials going on today. But to get to those trials, we had to first test this hypothesis that detection of tumor DNA in circulation post-curative intent treatment is truly identifying patients destined to recur, that the signal is a true signal and is indicative of recurrence. And so the way that this has been tested to date is in biobanked cohorts. So and it's been done across multiple tumor types, multiple different assays. All of you that have contributed to banking protocols, thank you on behalf of the space. So essentially what happens here is a cohort of patients who has been followed for 5 years, and the patient said, yes, you can bank my tumor specimen. I will give you blood draws at periodic time, and you can follow me and annotate if I was recurrence-free at 3 years and 5 years, or if my cancer recurred at some point in that window. And in these banked cohorts, those plasma samples have been analyzed, sometimes the tissue and the plasma, to assess, does the assay accurately identify patients who are destined to recur or who ultimately recur? And so I have a couple of examples to show you to prove to you that, yes, this has been shown, these assays are working. So this is a early stage 1 through 3 lung cancer banked cohort, where what is being shown here is the freedom from progression. So progression-free survival. The black line up here is the patients who had no ctDNA detected at MRD landmark. MRD landmark at this point means post-curative intent treatment. So they've gone through whatever the standard of care was for their stage, be it just surgery or surgery plus systemic therapy. And the patients who did not have ctDNA detected post-curative intent, you can see nearly 100% stayed recurrence-free out to 3 years. In comparison, the red line was patients who had ctDNA detected at that treatment blood draw. And the positive predictive value here is 100% in that all patients with ctDNA present ultimately recurred. And you can see it was actually a very short time, median time to recurrence, which is about 3 months on median, but there is a long tail out to a year or even further. And so, yes, in this instance, the ctDNA assay is distinguishing those who are destined to recur from those who, for the most part, stay recurrence-free or have a very distant recurrence. And another cohort with another liquid biopsy. So this is a breast cancer group. And again, you can see red line is patients that had ctDNA detected post standard of care treatment. All of them ultimately recurred, whereas those with ctDNA not detected, the black line, had a much lower risk for recurrence, and those who did recur, it was a much delayed recurrence. And so the question there is, if we then looked at those monitoring samples, would we detect still the recurrence early? And I did not pull that data in here, but the reference is here, and the answer is yes. If we take this black line and extend the blood samples beyond that single time point into monitoring, then yes, this black line nearly straightens out that the ctDNA does, when it is still not detected at all those samples, those patients remain recurrence-free versus recurring. And for one more example, just to prove to you that this data is robust, this is now a colon cancer cohort. Again, dark blue line, no ctDNA detected after the therapy. Light blue line or aqua line detected, all of them ultimately recurred. And this is a mix of tissue-informed approaches as well as blood-only approaches. So in this early stage population, both of the approaches are robustly performing. And when they are returning a result of tumor DNA is present, those patients, it is predictive of recurrence. So where do we go next? We prove that intervening improves the outcomes. And so there are two main trial designs that are that I've seen to date of how to use these liquid biopsies. So most of what we're seeing, particularly from cooperative groups and clinician-initiated trials, is the stratification approach. So you take an early stage patient, they've had all of their standard of care therapy, that the goal is cure, and at the end of that, apply the blood draw. And this time, given all of that data I showed you on the prior slide, having confidence and getting IRB approval to say, yes, if they are ctDNA negative, they are at lower risk for recurrence, and so they stick with the standard of care, which is monitoring. And then if they're ctDNA positive, and that is indicative of a recurrence at some point in the near-ish future, they actually then go on to receive additional adjuvant therapy. The goal here with that additional therapy is, we didn't get all of the tumor cells, we didn't kill them all off with the standard of care therapy, so we're going to give you more in attempts to improve your survival outcomes, and then do the necessary follow-up to prove that that works. The other approach that we're seeing, more so on the pharmaceutical trials, where they're looking to test an investigational agent. In early stage cancers, we know that trials to prove that an investigational agent improves outcomes are very, very large trials, because early stage patients are, hopefully the majority of them, are cured by the standard of care therapy. And so to have a powered study, we are talking about multi-thousand participant trials. What we're seeing from pharmaceutical companies is saying, actually, we want to enrich. We want to run smaller trials. We want to increase the signal. So we want to use these liquid biopsies to enrich, identify the patients who are destined to recur, and then give them the standard of care versus standard of care plus the investigational agent to, again, have a smaller trial design as well as a faster time to determining if that investigational drug is working or not. I am sure that there are other ways that these assays are being used, but as I looked across the different trials that have launched, it was really these two different approaches, so either stratification or enrichment. And to give you a couple of examples of trials that have recently launched, so COBRA is a randomized controlled trial to establish clinical utility in early stage colon cancer. So this is stage 2 low risk colon cancer, where the standard of care after surgery is surveillance. And that's because only about, depends on the population, but 10 to 20% or 10 to 15% of these patients ultimately recur. And so the question and the quandary that's faced by clinicians is, do we give chemotherapy to all patients to benefit the 10 to 15%, or do we go with the majority, go into active surveillance, and deal with the recurrence when it happens in those that are destined to recur? So that is a prime clinical quandary to apply liquid biopsy to see if you can actually improve and better identify patients and stratify them for who needs adjuvant therapy versus who's cured by surgery alone. So this trial design is about 1,400 patients, and that's because it is doing a randomization and then a stratification. So they're randomized to either the standard of care, which is active surveillance, or to ctDNA-directed therapy. To maintain the blinding, patients, it is not blinded. There is blood sample collected from both. For the active surveillance arm, it is being banked for retrospective analysis. And then for the ctDNA-directed therapy arm, the blood draw is run real time. And if the tumor DNA is positive, detected, they go on to receive chemotherapy. And if no ctDNA is detected, they stick with the standard of care, which is active surveillance. And so this trial launched end of last year, and you can see that the primary completion date is about 2.5 years out, and full study completion in 2024. So this will take a number of years to accrue and be followed for outcomes. Not being applied routinely in clinical care today. I think we're all familiar with clinicians that are at the cutting edge of technology, and technically there are liquid biopsies available to clinicians today to potentially use this way. And so we do see some oncologists attempting to apply this outside of a trial, but the majority of clinicians are looking to either become a site for these types of trials or set up an investigational trial and leverage liquid biopsy through a trial designed to capture the outcomes, improve the efficacy rather than routine clinical use. And just one more example for a little bit different way to use liquid biopsy based upon the stage of disease. So this is a stage 3 colon cancer trial. Stage 3 colon cancer, if treated with surgery only, about 50% of those patients would ultimately recur. So standard of care is to give chemotherapy. And so these patients go through their surgery, their standard ranging from 3 to 6 months of chemotherapy. But the other thing we know is that even after chemotherapy, about 20 to 30% of stage 3 patients, stage 3 colon cancer patients do recur. So clearly there is still a subset of the patient population that is not cured by chemo plus surgery. So this trial design is saying you've completed standard of care. We expect about 30% of you to recur. So rather than stopping there, we're going to do a blood draw, a liquid biopsy. If you're ctDNA negative, you continue with standard of care follow-up and surveillance. But if you're ctDNA positive, you go on to receive additional therapy, adjuvant systemic therapy. And this adjuvant therapy is being applied in a biomarker-directed way. And the biomarker is being driven by the tumor sequencing, not the blood draw, for reasons I'll explain in a moment. But essentially, if they're MSI high, going on to receive nivolumab, which is an FDA-approved agent in the advanced stage MSI high tumors. And then if they're microsatellite stable, if they're BRAF V600E positive, targeted therapy, and if no biomarker, genomic marker of interest, go on to receive additional chemotherapy and then monitoring. So the reason that this biomarker-directed approach is not based upon the blood draw, but upon the tumor tissue, is because the goal after chemotherapy and surgery is that we've killed all or the majority of the tumor cells. And so the signal in the blood is very weak. And the result right now for these liquid biopsies used in this use case is simply detected, not detected, not as a genotyping assay. I would predict that as these liquid biopsy assays become even more sensitive, that could change. But today, the use case of is the tumor killed or not, it's really a yes or no binary answer as opposed to a genotyping solution. All right, so, oops, I lost my screen, give me one moment. And then just to give you a couple of other examples that we spoke about, the first two, those colon cancer trials I just walked through, those are cooperative group trials that are being applied given the clinical quandary that's already known in that cancer type. Who do we give chemotherapy in stage 2 patients and in stage 3 patients? Even though we've given you chemotherapy, we're not curing all of you, so we need to do more. On the other side, we talked a little bit about how pharmaceutical companies are using the ctDNA assays or liquid biopsy more for enrichment. And this is just a couple of examples from 3 different companies. And you can see, again, the timeline for these trials. They started either last year or will be starting this year. So these are new trial designs, and they will take a couple to 5 years to read out. And so again, this is the use in early stage disease is being developed and proven, the clinical utility is being proven. Because the assays are available, we anticipate some clinicians will start to order it, but the majority will be involved in clinical trials to develop the data for routine use in this way. And so the potential routine uses in the future, not too distant future, but not immediate, are blood draws potentially to identify which patients need adjuvant therapy after surgery. Blood draw, liquid biopsy can help identify potentially patients who need less or more adjuvant therapy. So I've seen trial designs looking at what if we apply liquid biopsy halfway through the chemo regimen and see if that's enough. Maybe we can give half the chemotherapy instead of the full regimen. Or patients who complete the standard regimen, but maybe they need more. So can we become more personalized in how much therapy to give a patient? A bit more aggressive, but starting to see, especially in rectal cancer, some trial designs around, can liquid biopsy identify patients who need surgery after neoadjuvant therapy? Perhaps we can cure the patient with purely systemic therapy and they don't need surgery. That is a pretty lofty goal, but not one that will be unheard of in the future, I don't believe. And then also talking about using liquid biopsy as a monitoring tool to look for that early signal of recurrence, to then trigger early intervention to improve survival. Again, trials going on there. And as we're thinking about using liquid biopsy to monitor for early signal of recurrence, that dovetails into also then monitoring for early detection. So with that, I'm going to transition now to the data in the trials for screening utilization of liquid biopsy. And I know we have, I'm coming up on time, so I will breeze through these to leave time at the end for questions. But as we think about liquid biopsy for screening, I had to take a step back. I worked more in the cancer treatment realm, and so had to do a little self-education around the screening use and some of the differences there. And so as we think about a screening test, the goal is to identify as many true positives as possible, so that high sensitivity, but also minimize the false positives, so high specificity. But we cannot have the best of both worlds. It is very nearly impossible to get 100% specificity and 100% sensitivity in a screening test, because there is a trade-off. When one increases, the other decreases. And so for a couple of examples, so this is a breast cancer screening comparison that I found, and I will fully admit I chose this example because it's very demonstrative, but this is from a 2009 article. It may be outdated. If you work in breast cancer or in a mammography suite, please do not take these numbers and apply them or assume they are completely accurate today, because this is an older study. But what it does show for demonstrative purposes is that as we go from mammogram to ultrasound to MRI, the sensitivity increases. We are finding more patients with the more sensitive assay, but the specificity decreases as the sensitivity increases. So while we find more true positives, we're also finding more false positives. So we're creating fire drills for patients. And as we think about a screening test and which population we apply which tool in, we have to balance the true positive to false positive ratio to figure out what screening modality best fits the use case. These ones are fairly, there's not a huge difference as we go from mammogram to MRI here. A much more extreme example is if we look at PSA screening for prostate cancer. Again, this is an older article. I chose it for demonstrative purposes. I would not recommend blanketly taking this as today's status quo. But what we see here, so PSA is on a scale, a numeric scale, and we know that this antigen can be elevated for both benign and malignant reasons. And so what we see here is that if we choose a lower and lower PSA cut point for the screening assay, the sensitivity increases in terms of the number of cancers that are diagnosed. But you can see that the specificity drastically decreases as that cut point changes because of the benign reasons that a PSA level can be elevated. And so there was a lot that went into determining what was the right cut point for PSA screening for prostate cancer. And so I think this really nicely shows that trade-off that exists. And what that dovetails into is then how we look at what's been going on in the liquid biopsy space for early detection. And most of the work to date has been looking at how are these assays performing at detecting across the different stages at different or predefined specificities. So there's these levers you can pull, and depending on the cancer type, depending on the performance, depending on the existing standard of care for screening or lack thereof, you can kind of tweak in one direction or another to say, I want a very high specificity, so the sensitivity is going to be lower, versus I'm going to accept a lower specificity to increase the sensitivity. But then what do you do about that? And so for that, given all of kind of these complicated pieces, it will not surprise you that if we go back to that list of the more than 100 companies that are developing liquid biopsies, only about 20% of them are focused on early detection. This is the harder lift. This is the holy grail. We're looking for, can we have a blood test to identify and diagnose cancer? But it is much, much harder than what liquid biopsies have done to date. And as a reminder, for primary screening, as we think about the different methods that are being applied, all of this work, again, is in that blood-only approach. And one of the things I found when updating the data is that it's not only blood-only with genomic and or epigenomic signals, but also bringing in some artificial intelligence, machine learning, to see if that helps as well. So let's go through what the assays are that have been presented data to date, how they're performing, as well as the handful of trials that have started. So this data is from a methylation-only assay looking at pan-cancer detection. This was presented at ASCO last year, and you can see that they set the specificity very high, 99%. And so not surprising, given the high specificity requirement, the sensitivity at stage 1 and 2 disease is a little bit is on the lower side. So stage 1, in the pre-specified cancers that they knew that the methylation assay was designed well against, the detection rate in stage 1 was 40%, and in stage 2 was 70%. And looking at an all-comers approach, the stage 1 detection was 20%, and the stage 2 detection was 40%. When we get to stage 3 and 4 cancers, the more advanced cancers, 80 to 100% detection. And so this is a very positive signal that this approach can work, but 20 to 40% detection rates in stage 1, 40 to 70 in stage 2, is this meeting the goal of screening to find and diagnose cancers in early stage? That is open for debate, discussion. I have my opinions, but I will save you from those because it is an opinion. So the other thing that we can do is say, okay, what are the ways that we can continue to improve upon this? Well, maybe we need to focus on cancer types where we know the technology works. So this same group at ASCO GI 2 months ago presented the assay performance focused just on GI cancers. Some of the GI cancers are a bit more what I call methylation happy, where they have a nice methylation signature that is detectable and differentiated. And you can see here that if they focus on GI cancer detection, the sensitivity is nearly 50% for stage 1, 75% for stage 2, and then higher again at 3 and 4. But seeing a more robust detection rate if we focus in on cancer types that this assay is performing well for. So this is the data that I was able to find related to the methylation-only approach. Another approach that was published 2018 was looking at genomics only, but doing whole genome sequencing rather than a predefined panel in the cell-free DNA space, as well as that artificial intelligence component. And I can tell you, I could not find any details on the AI component. It appears to be very proprietary. So I cannot answer questions on that. But what you will see here is that this group focused on performance in colorectal cancer. They set their assay specificity at 85%, as opposed to the 99% we saw in the prior group. And with a lower specificity, also a different assay approach, their sensitivity ranged from 75 to 82%. And you can see in the purple here is stage 1, like 75%, stage 2, 80%, and then stage 3, also 80%, stage 4, not surprisingly, 100%. So by lowering the specificity threshold, we're seeing higher sensitivities, but also a different assay approach. So it can't deconvolute without a head-to-head study how much of this sensitivity performance is based upon the methodology of the technology versus the specificity threshold being set lower. Another assay that has reported data is one, so we looked at one that was methylation only, we looked at one that was genomics only. This is an assay that is genomic plus epigenomic, focusing on colorectal cancer. This group presented at AACR last year, and they broke out the assay sensitivity at different target specificities. So you can see here at a 90% target specificity, the sensitivity was 90%. Across colorectal cancer stages. At a 95% target specificity, only a modest decrease in sensitivity, so a gain of 5% specificity for only a 2% loss in sensitivity. And then to go to 98% target specificity, you can see there that then the sensitivity drop is about more than 10% down to 80. And this group also did break out this performance by stage. And one thing that I'll note for you, so if we go think back to the methylation only assay that we started with, where they had predefined their specificity at 99%, their stage 1 performance was around 40 to 50%, which in this assay, if it was genomics only in content, it would have been sensitivity at stage 1 of 44%. The addition of the methylation signal took the assay sensitivity up to 64%. And you can see as we move down the specificities, the major gain in sensitivity is primarily in the earlier stage diseases. And so the quandary here in the clinical realm is, okay, we can clearly increase detection rates of early stage cancers if we lower the specificity threshold. But again, that question or that trade-off is, what does that mean for absolute numbers? How many patients are getting a false screen positive? And most importantly, what is the follow-up to distinguish true positive from false positive? How invasive versus not is that? To really think about what is the right balance to bring forward into the clinic. And I do not have the answers for you there, but want to share kind of the thought process and what is going into the design and validation of these assays. All right, so let's see here. I will breeze through these last couple slides. So moving away from the technology and the data that they have shown to date at detection rates across stages, I found 2 trials since the time. I found a second trial beyond Eclipse since the time when this was submitted. So AI Emerge was a colorectal cancer screening trial of about 3,300 participants. It was a mixture of enrolling patients who were recently diagnosed with colon cancer, as well as the majority were going under screening colonoscopy. Goal was to look again at detection rates across stages, as well as the specificity and sensitivity in the screening population. This was a multi-omic blood test, so this is a genomic and epigenomic test, and you can see a specificity of 94%, 90 to 94% sensitivity, so very nice performance here. And the conclusions I found from their recent presentation is that these results will be validated in a prospective multi-center registrational trial. So this is more of a signal finding trial, not one that would be leveraged to move into either FDA approvals or Medicare coverage when it comes into a large prospective follow-up study. I looked yesterday on clinicaltrials.gov as well as the company that is running these trials, and I could not find any instance of this registrational study yet to tell you about in case clinicians that you work with be of interest, but the AI Emerge trial NCT number is on the bottom, and if this is something you're interested in, I would encourage you to monitor for this pending registrational study that I have not yet found online. The other study then is Eclipse, which is evaluation of ctDNA lunar assay in an average patient screening encounter. This is a much larger prospective trial of more than 10,000 individuals at average risk for colon cancer, age 45 to 84. It is going to be enrolling from up to or more than 100 sites in the United States. The design is screening colonoscopy versus the blood test, with the goal of evaluating performance of a multi-omic ctDNA test, so again, genomic plus epigenomic, in average risk adults. This is a regulatory grade study, so in theory, this could be used with things like the FDA or CMS. And this study started in 2019, primary completion in 2022, full completion in 2024. So still a couple of years out until we get we find out if this blood draw works equivalently or better than colonoscopy, or equivalent to, not better than. So the hypothesis, given the webinar objectives, I pulled forward the hypothesis, which was that the liquid biopsy test under study has adequate sensitivity for the detection of colon cancer and specificity for the detection of advanced neoplasia compared to the reference standard in a screen relevant population. Design is multi-center prospective, non-randomized. Statistical methodology is conditional power and group sequential design, and the acceptance criteria, there is a predefined sensitivity and specificity. I could not find those. They appear to be confidential, but in keeping with historical precedent for the intended use. Some of you may be wondering why target colorectal cancer for a blood test when there's existing screening options. And in general, the rationale here is that data that's been published shows that only about 2/3 of patients are up to date on their colonoscopy or their colon screening. We know that the colonoscopy is the gold standard, but it is invasive and time consuming. So can we improve compliance and adherence to screening with a non-invasive test? In addition, because there is a gold or reference standard, the assay, the trial design can be done in such a way that it is in comparison to that gold standard, as opposed to something that does not have a reference. How do you define success in that situation? And briefly, there are 2 studies ongoing that I could find beyond colorectal cancer in this space. So the Pathfinder study of 6,200 participants, which appears to be purely in the UK. This one is focused on the impact to clinical practice. So with application of a blood-based screening tool, what happens when the blood test comes back positive? What are the number and types of diagnostic tests required to distinguish if this was a true or false positive, and what is the time required to achieve diagnostic resolution? And then for a validation of a multi-cancer blood test. This is a 50,000 participant study that initiated a year ago, and it will take a number of years to get to the primary completion date and then out to 2030 for the full study completion. So you can see, to validate a blood test in multi-tumor detection, a very, very large study, very long lead time, but we have to start now for this progress to move forward. So with that, hopefully you feel comfortable that what I walked through today is that while ctDNA is in use today for advanced stage disease, when it comes to use for early stage cancer, as well as in screening, that is in the future and not too distant future, but not available for routine clinical use today. And with that, thank you. I know we're at the top of the hour. I'm happy to stay on and answer any questions that folks have, or you can submit them via chat or email. Thank you very much.
Thank you so much, Kim. That was an excellent and really enlightening talk. I know as Kim mentioned, we are at the top of the hour. We actually don't have any questions logged in the question section. So I'm going to, since we are at the top of the hour, go ahead and wait maybe about a minute. If anyone has any questions that they'd like to type in, there's a section in the GoToWebinar menu. And for those of you who may have had any, we got a few reports of some audio trouble. This was recorded, and so we will make this recording available. Also, it will be available for those who could not attend today, but are interested in collecting CEUs by watching the video and answering the quiz. All right, well, it doesn't look like we have any questions coming in, so I'm going to go ahead and sign off then. And thank you so much again, Kim. Really appreciate your presentation today. And be on the lookout for the next email coming out with details on the next webinar.
All right, thank you, everyone. Have a good rest of the day.